Hi there, folks. My name is Eric Katz. I'm the Chair and Associate Professor at the Department of Emergency Medicine here at the University of Arizona College of Medicine in Phoenix, and also at Maricopa Medical Center just down the road. Today our topic is going to be remediation. This is a talk that was initially created for residents but applies to med students just as well as it does to residents. So when we think about remediation, or when we think about one person struggling within a class, I like to use this picture. We all see that there are three frogs that are hanging out doing fine, and there's one frog, and the question is that frog going to pull himself back onto this branch, or is that frog going to fall? Now, that frog who is going to fall, for our purposes, is going to be our resident or medical student who needs remediation. So, if I give you a stick, there are probably three ways you can affect this outcome. Now, if you're like most people, you're thinking to yourself, I can knock the frog off the branch, and for whatever reason, that's the way people go first. They're thinking about, can I knock the frog off the branch? But there are two other things you can do. You can use that stick to lift the frog up and put him back on the branch, or you can sit there, hold on to the stick, and do nothing, and see what the frog does on his own. And that's a pretty good analogy for remediation, because when we have a struggling student of any kind, we can knock the person off their branch, we can help them up, or we can do some appropriate poking and see if they pull themselves up. And we're going to talk about when you're going to use each of those approaches today. Now, you might know this resident. You probably trained with or have someone like this now. You see that he's going to be working with you today, and you just cringe, and because no matter what is done or what is said, he just never seems to get any better. And really, what you'd like to do is see him transfer out, quit, do something else, find his bliss elsewhere, because he just isn't very good. And the question I would ask you is this a resident who needs remediation? Or is this a resident who's probably okay and whose issues aren't going to affect his competence as a physician? Or is this someone who really isn't cut out for this line of work at all, and he shouldn't be remediated, he should be encouraged to find his bliss elsewhere? What about this guy? Very nice, totally trustworthy, always works hard, just doesn't seem to know very much. We've all worked with folks like this, and we're going to talk a little bit about when you help, and when you use that stick to lift the person up, when you use the stick to knock them down, and when you just stand there and see what they do. So if you've known this resident a year later, have they been any different? And if not, why not? And how can we keep that from happening? Does this person need remediation? The question I would always ask there is this person fixable, or is this person unfixable? And if they're fixable, is this something that rises to the level of a formal remediation plan? So you've probably worked with this person as well. Very bright, very organized, very responsible, easy to get along with. People like working with them, but they develop a medical issue that makes them not as good. So for example, if we take someone in a procedural specialty and they develop an intention tremor, is this a remediable problem? Well, it actually might be if there's a treatable medical condition. If it's not a treatable medical condition, this is obviously not someone we remediate. So, the last one, hardworking, bright, dedicated, very personable, going to be a chief, but all of a sudden showing up late, scrubs are wrinkled, not shaving, just not on his game. Still competent, but nowhere near what they used to be. Does this guy need remediation? We're going to talk specifically about this person. So, whenever you have a resident or any student who has problems, the questions we're going to ask is, what is remediation? What are the rules behind remediation? What are the stages of remediation, and how does it affect you? How should you act when one of your residents is in remediation? And then when does fit for duty assessment come into play? Now, through all of this, I'm assuming that you are not the residency director and you are not the dean of students, because those two will have a very different role here. This is a talk aimed at faculty or chief residents or anybody in a supervisory role who wants to know how best to work with a struggling student of any kind. So let's ask the question, what is remediation? Because most people will say the act or process of correcting a fault or deficiency. And that begs the question of which residents or students have faults or deficiencies. And the answer is probably all of them. So, do they all need remediation? Well, probably not. The reason they don't all need remediation is because these may not rise to a level where they are impeding the person's ability to be a safe practitioner, student, resident, whatever their level. So for our purposes, we're going to change that definition a little bit, and we're going to say it's attempting to correct areas where performance is beneath some minimum standard. So if you're a physician or in any way associated with medicine, saying the word standard is a big red flag waving in a field, because there are tons of standards out there. We have JACO over here, we have DNV for those that don't use JACO. Within education, we have the ACGME or the LCME, we have program director societies, we have clerkship director societies, we have dean societies, and then we have the public society, what the public thinks of our work. Because let's face it, every once in a while, one of these problem residents ends up in the news. And so we're held to a standard by the public that's probably far higher than any of the others here. But for our purposes, we have to define our own standards. So at Maricopa, we've defined the Maricopa standards. The U of A has its own standards. The state of Arizona will have its own as well. So, for lack of a better comparison, the ACGME, which is the Accreditation Council for Graduate Medical Education, is the educator's JACO. They create the rules by which residency programs are run. If you're talking about medical students, they create the rules by which the students are educated. And ACGME has said that remediation has to be linked to something, has to be linked to a specific core competency about the residency program, something the residents absolutely have to know to be good doctors. It's tied to specific job requirements, and it's tied to feedback and defined objectives, preferably things that are quantifiable. And that part is absolutely key, because if we have a resident and we don't intervene and give them feedback and point to the thing that they're specifically doing wrong, they will not get better. So each target of remediation has to be labeled to something that's core to the requirements of the residency program. So for example, if I'm a psychiatrist, the fact that I develop an intention tremor may have very, very little implication. But if I'm a surgeon, that absolutely has a huge effect on my practice. Because of that, the same deficit in different specialties may cause different remediation efforts. And so we link them in education under these 6 core competencies: patient care, medical knowledge, interpersonal communication skills, professionalism, practice-based learning and improvement, system-based practice. Now, your specific niche, whether it's medical student education or whether it's a procedural specialty, may have other areas. But at some level, the deficit must be linked to something intrinsic to the specialty that is being learned. So, remediation has to be linked to the job requirement, because we otherwise are telling the resident they have a problem without pointing to why that problem is important. And that gets into some employee relations and human relations issues, because if we tell them that we have to fix something and it has nothing to do with their job, we can actually be legally liable for that. So if I'm a psychiatrist and having a tremor doesn't affect my job, and I discipline or terminate the resident because they've developed a tremor, it's easy to see why that would be a problem. So it has to be something that's linked to the job. The harder one to see is that sometimes, for example, professionalism is not a career-limiting issue. In other specialties it is. If I'm a psychiatrist and I can't talk to patients, I have a major problem. If I'm a pathologist, much less of a problem, so long as it doesn't create an unpleasant work environment. So, do we have job descriptions for residents and for medical students? Absolutely. We have medical student level specific goals and objectives. We have postgraduate year, and PGY here stands for postgraduate year. Postgraduate year goals and objectives. We have rotation goals and objectives. We have technical standards. We have policies from every level. We have resident and medical student manuals. Those are the areas where we're going to find our targets to describe where a resident is struggling. So remediation has to include feedback and goals. The reason is pretty clear. If you don't give someone feedback, they don't know that there's a problem, they don't improve. What's more common in medical education is we've given them feedback, but we've done it in such a blasé or grade inflated manner that they cannot see that there is a problem. So we are using remediation to formalize the old OFI, the opportunity for improvement or opportunity for enhancement. And we're going to use our remediation pathways to track it. We're going to talk about when we stop tracking it, and most importantly, we're going to talk about how we document it. Because even though if you're listening to this lecture, you're not a program director and you're not a dean of students, we still need to be documenting it, because otherwise we are tying the hands of those individuals and we are actually preventing them from making the changes in this resident or medical student that we'd like to see. Now, a concept that I'm going to say pretty frequently today is that our job is to present the opportunity to the resident to improve. It is not our job to drag them across the finish line. If they choose not to make the changes necessary, or if they can't make the changes necessary, we're not going to keep going with that failing student. We're not going to keep promoting them and let them be out in the real world without supervision if they're not capable of doing the job. And that's going to be something I'm going to come back to over and over today. So, who does the remediation? Lots of people. In my mind, the resident being remediated is absolutely the one who's responsible for this. As educators who care about our students, we want them to succeed. We are so driven for them to succeed. We see our own success in their success. And what that means is that when a resident is not capable of doing a job, or when a student is not capable of becoming a physician, we very often are so invested in their success that we fail to see it, and we fail to take the steps necessary to really protect the patients from this person when they move on. So, with the resident being remediated, the resident is absolutely the person who's most responsible for that remediation. Now, the program is also responsible. The program director, the graduate medical education committee, the faculty, if you're a student, your progress committee, your med school, those are all in there with them. Those are all the groups that are going to be providing them with their opportunities to succeed. But at the end of the day, it's the resident who's responsible. So who doesn't do the remediation? Well, the patients don't do the remediation. We can't have a struggling resident in a situation where they can't actually do their job and take care of the patients. The nurses don't do the remediation. The support staff doesn't do the remediation. Now, all of those groups may provide valuable feedback to it, but they're not the remediators. Most importantly, the lawyers don't do the remediation. So when we talk about remediation, we talk about things like employee law. We talk about human relations. Those are key, but we're not going to let our legal staff tell us what we can and can't do with remediation. We are going to follow their advice to the letter when it comes to what is legal to do and what is not legal to do. But they're not the ones who have to, at the end of the day, sign off that a student or a resident is fit to graduate to the next level and have less supervised care of patients. So what's the average faculty member's role? We build that path to success. And like I said before, we want them to succeed. So it's our job to build the path. It's the role of the resident to put the pieces together, to be able to follow that path to become successful. So do we remediate everything? I would like to divide problems into fixable and unfixable. And if you think through your mind, what are the fixable problems? What are the unfixable problems? Under fixable, you probably had things like medical knowledge. You probably had things like most professionalism, being nice to the nurses, signing your charts, doing your notes. Most interpersonal skills. Not all of them will be fixed, but most of them are fixable. Now, on the other hand, there are things that are not fixable. Severe behavioral abnormalities. The person with the personality disorder may very well be unfixable. The person who's lacking absolutely essential skills. This is where our tremor comes in. And then there are the ones where we say, this is not something we're going to remediate it, you're just not repeating it. So let me give you an extreme example. The resident or medical student who comes into work and you think they're intoxicated. Can we fire them immediately for that? In some systems you can, but in most of them there's employee law that prevents it. And that's something where you're simply saying, this is not remediated, there are going to be steps for ongoing monitoring. If it's repeated, you're fired. And that's a step we have to be willing to take. These are not always inevitable, but we have to remember that not everything has to be fixed. We can't be so wrapped up in their success that we forget the fact that sometimes they're just not going to be successful. So, where do medical issues, fatigue, substance abuse, psych come in? It depends. It depends on how bad the issues are and where they come in and how they show up. So, almost all the rest of this talk is case-based, and that's the good news, because we've all seen this frog. We've all seen this guy hanging out here who may fall or may pull himself back up on the branch. The bad news is that I'm probably basing this on someone you know and someone you've worked with. So, tell me if you've seen this resident. Guy works really hard, tries really hard, he's professional, shows up on time, does his work, never needs to be asked twice, but he just doesn't know his stuff very well. They're very good at following directions. When they present a case to you, they are very much of a reporter and they are not synthesizing anything on their own. The program, though, that they're in may not have a lot of objective testing. And so what happens, this is the person who we say, hey, you're doing a really good job, but you need to read more. Does this person need remediation? It depends. Does his medical knowledge cross that threshold where they're not meeting expected standards? If so, then they need remediation, and it should be formal. If it's at a level where, yeah, they're a little low, but if he reads, he'll catch up, maybe he doesn't. Now, if you don't have a lot that's objective, and now his in-service score comes back and he's in the 7th percentile, while I am not in favor of using a single test score to determine remediation, in this case, the test score confirms what we already know, and now we have a problem. So where's his opportunity for enhancement? These are the 6 core competencies that the ACG and me used to use. They're as good a heading as any. In this case, we can probably say that his problem is right up in here, right up in medical knowledge. The reason that's so important is that medical knowledge will then spill out into patient care, and it may spill out into system-based practice. So his core problem, though, is medical knowledge, and that's where we're going to focus. So what normally happens is people say, you got to read more. That in-service score was just not good enough. You got to get better at this. And so he becomes a PGY2. He's still hardworking and professional. People still like him. He still follows direction well. And now he's developed pattern recognition. And if you study medical errors, you'll realize that falling back on pattern recognition is one of the easiest ways to cause trouble for yourself. But he still has a poor grasp of medical knowledge because, let's face it, when we tell people, hey, you need to read more, a lot of them don't read more. And so these folks develop this shotgun approach to managing patients. I have someone with chest pain. I'm going to look at them for cardiac issues and pulmonary issues. And if that doesn't work, then I'll turn to GI. But what they lack is the ability to say, hey, this person has chest pain, but this chest pain is GI. We need to start there, not do the extra CAT scan, not do the stress test. We need to start at GI. Does this person need remediation? So the only difference between this slide and the last slide is I haven't given you the in-service score yet, and he's now a PGY2. And for this sake, let's say it's a 3-year program. So he is now 2 years into a 3-year program. Does he need remediation? Almost certainly, because what we're describing here is a persistent pattern that is not letting the person get to acceptable standards. So the fact that his in-service score comes back at the 10th percentile, maybe he's shown some growth because, let's face it, 7th percentile intern year and 10th percentile second year imply that he's stayed with the same group. I think the difference between 7 and 10 is probably statistical noise, but there is a growth between first and second year, mostly based on pattern recognition, and this guy's done that move. So far, what have we told him? Well, we've probably told him, hey, you need to read more. When we found specific deficits, we've given him an article. We've told him, hey, you got to get that information from the article to the patient and make that knowledge translation. And here's the thing that kills us. You have the makings of a really good doctor. People like you. People like working with you. I'm really glad that I never have to repeat myself and you follow through and you show up on time. You know, your limiting factor is your knowledge base, and that needs work. And we're going to show exactly why that fails. That's the old sandwich methodology of feedback. The sandwich methodology was praise, formative feedback, more praise. It used to also be called the stool sandwich because you'd be having the meat on, you'd be having stool on bread with compliments. So you put the stool in the middle, you put the compliments on the outside. That theory has kind of passed on now, but this is what the student has been told. You've got the makings of a good doctor. So on their evaluations, if you think about your residents or your students and whatever scale you use, 9-point scale, 5-point scale, what do you think his evals are going to say? Because if you look at all patients in remediation, in formal remediation pathways, written down, signed off on, run by graduate medical education or student progress, almost 20% of them have no evidence on their evaluation that they are beneath acceptable standards. So 1 out of every 5 that we're saying are already in remediation don't have a bad evaluation anywhere. Grade inflation is everywhere. I'll give you a specific example of that in a sec. And then here's the key part. Faculty, so the folks in your shoes, may not even know what to document because they want to be part of the solution, but they don't want to label the person or write something bad in their file for whatever reason. Maybe you're just good people and don't want to risk the person feeling bad. Without that, though, we lose the opportunity to show them the problem. So we know that the example I've given you has a specific medical knowledge deficit, and this is the one that most people think is most common. What happens in his other evaluations? And there are two patterns that are very common. The first pattern is, I don't like to give bad grades, so I'm going to give him 6 out of 9. But normally I give 7 out of 9, so 6 is kind of weak. Maybe I'll even give him a 5. But if you think about it, a 5 out of 9 is mean. Residents see 5 out of 9, they think I'm doing average. You know it's a bad grade. They don't know it. The second thing that happens is you get what's called grade slurring, which is, well, I think this is a really good guy, so across the board he's going to get straight 7s out of 9 or straight 5s out of 9. And what we don't do is we don't take the time to credit them where they're really strong and to hit them where they're really not. And when I say hit them, I'm using that intentionally because we feel like we're hitting them. What we really need to be thinking of is, where is the message I'm trying to deliver? What's the weakness? How do I communicate that to them? Because what often happens is the faculty feel like they've put something on an evaluation and they feel like the program director ignored it. So if you look at the written comments, those detect deficits much more commonly than the numerical ones do, because so many people are reluctant to give a grade below the mean or even at the mean. So within written comments, technical skills are the ones that come up most because those are the ones that no one can argue with. If I have a tremor, if I accidentally ligated the wrong artery, you can't argue with that. That's objective. Knowledge, reasoning, and behavioral stuff is almost never in the comments, and that's actually probably the vast majority of the problems we see with residents. So we use new innovations. So for example, the resident that I'm describing here, their mean was 6.7 on a 9-point scale. Now again, a 5 should be average, but we're giving this guy a 6.7. Why is that? Because he's a good guy. We don't want to hit him on everything. We want to hit him on the targeted areas, but what that means is overall, he's getting a message of, I'm above average. Now, you and I may lock in on this class mean here and say, well, the average is 7.7 on a 9-point scale, and by the way, that's absolutely typical of most residency programs. The average resident is in the exceptional category. Let's face it. We may think our residency or our medical school is better than everybody else's, but there's no one out there who says, you know what, my residency is really much worse than average, and therefore our mean should be a 4 out of 9. Of course not. All of us have means above 5. So what this person has seen is, good guy, needs to read more, keep reading, he tried really hard, his fund of knowledge is improving, which to you and me is code that the fund of knowledge is really weak. To the resident or the student, they're thinking, hey, I'm getting better. So that's the difference in how we all read this data. So overall, if I'm a student and I read this data, if I'm a pessimist, I would say, well, I guess I met expectations. I'm below the mean, but I'm above the average. I'm below my class mean, but I'm above the average for the training program. So that's not bad. Many would see this as, hey, I'm above the mean. So most boards take this into account because they don't want comparative grading. Their exams are non-competitive. If you think about your licensure exam, it was almost certainly non-competitive. A competitive exam is one where a set percentage will fail. So if I have an exam where I'm going to fail the bottom 5%, that's a competitive exam because you're telling the person, I don't care how much you know, I'm only passing 95% of you. On the other hand, most boards don't work that way because we understand that there's a certain minimum threshold, and it would be amazing if everybody were above that threshold. And if everybody passes 1 year, it doesn't mean the test was too easy. It means we did a better job of educating. So what has the resident heard with all this? They've heard, I'm a good doc, I'm working hard, people like me, I probably need to read more, and my medical knowledge is getting better. Everybody needs to read more though, so yeah, I might need to read a little more than the other guys, but I'm still progressing. So how is this resident different? I'm going to give you a different resident now. They're third year, they're hardworking, they're professional, they're well-liked, their in-service score is still in that bottom 10 percentile range, follows directions well, can do pattern recognition, still has bad medical knowledge, and shotguns it. Well, this is obviously the same guy, but he's a third year, and this is what we see time and time again. Because they're a good guy, we ignore the flaw. We now have late recognition because in PGY1 we think, well, they're an intern, they'll read more. In PGY2, well, they're a little behind, but we still got time. And then they're a third year, and we're stuck because we haven't remediated the person. And as faculty members, we feel like the program director or program didn't do its job and jump in there and fix the person. But in reality, we never gave them the opportunity to because we haven't given them the feedback. We haven't given them the evaluations that say there's a problem. So in April of their last year, we think, oh my God, this kid is going to get turned on unsuspecting patients, and that's going to cause a problem. But we can't hold them back because we'll get sued, because it's not fair. They're third year. And we're caught in this conundrum. This is a bad place to be, and I think we can all agree that figuring it out in third year is not good enough. And the time to intervene on this kid is probably late first year. So we need documentation to do that, because otherwise the program director's hands are tied, because if the resident accepts that there's a problem, you can do anything. You can always fix them, but chances are that person got fixed early. It's the resident who says, what are you talking about? I got a 6.7 out of 9. You can't tell me there's a problem. So what have we done? Well, we've given positive verbal feedback. You're a good guy. We've given formative feedback. You need to read more. We've given written feedback because we said you need to read more. We've talked to the PD about it. The PD has their own documentation from their semi-annuals or from whatever discussions they've had, and we've had the advisor say you really need to read more. What have we documented, though? Because all of those things have happened, and everything here on this side of the screen absolutely needed to be done. But without the documentation piece here, it's very hard to track that we have documented a problem, and it's very hard to get around the fact that they need formal remediation. So verbal feedback counts as documentation if you write it down somewhere. So for example, when an attending comes up to me and says, you know, I saw Jane Doe do a central line, and she's a second year, and she ought to be able to do a central line, and she had no clue what she was doing. I actually, if this is anything that I think might lead to a formal remediation pathway, I go to my email and I email myself a message that says, spoke with Dr. Smith, saw Jane Doe do a central line. If I have the patient identifier, the MRN number or something, I'll put it in there, and I'll put in there that there was a problem, and I'll email it to myself. Now I have documentation of verbal feedback, and I didn't go through any big process. I sent myself an email. Every resident I have and every faculty member I have has a folder on my email with these sorts of things in it. Now that folder also contains the compliments. It's just as important to keep those, because if Dr. Jones comes up to me and says, hey, I saw that same resident do a central line. They did it beautifully. It was a really complicated patient. They did amazingly well. I need to save those too. So, written feedback. Is it consistent with other evaluations, or is there one bad eval? If there's one bad eval as a program director, I want to go in and investigate it and say, hey, what happened? Did something happen to the resident, or was there a personal interaction? Was there one bad patient that stuck in the evaluator's mind? What happened? And I want to say, is that written eval, is that consistent with minimal standards? Because if that one eval is not consistent with minimal standards, I have a resident who's repeating a rotation, or I have a student who's repeating a rotation. So what goes on your evaluation? Think about, when I write an evaluation, the first thing I think about is, what do I want them to learn? Because if I know what I want them to learn, I can say that. But if I don't take that 3 seconds to think about what's the one take-home point I want them to get, now sometimes it's 3 take-home points. You're dressing unprofessionally, you're treating the nurses mean, and you need to read more. I have to write something about each one. It has to be very pointed, because most medical students and most residents really are smarter than the rest of the world. Let's face it, that's how we got where we are. We have a high IQ. Folks like that are rarely told they're doing something wrong, so this is going to be new to them. They're used to seeing an evaluation as praise with maybe something they can gather from. So write out what you want them to learn, be specific about it. If they have a specific problem, focus on it. So the case I gave you here, whereas PGY 1, 2, and 3, we kept saying they need to read more, I think you have to say there are significant deficits in your medical knowledge. The areas that we found included evaluation of chest pain, evaluation of PE, use of endoscopy in workups. However, I think your medical knowledge deficit may be more global. Write it down. Yes, that may hurt a little bit, but it's going to hurt more in third year when someone says you're going to kill people, or worse, when they're a third year and they do harm someone. Discuss if there's specific bad formative feedback. You should always discuss an evaluation with each rotator. I know that's a very new school thing to say, but messages don't get communicated by forms. When I get a form that has a bunch of boxes checked and no comments, yeah, I skim it. If they're high scores, I feel good. If they're low scores, I feel bad, but I don't get anything from that. It doesn't tell me what to fix. But 3 minutes with the person who filled out the form telling me where I need to improve, that's gold to me. And to your students it is too, because most students are really good folks and they want to learn. So give them the chance to learn. At the same time, ask them the question, what could I have done to help you learn this better? Because the next time you have that same resident, you don't want to create the same mistake. Listen to their response. That'll tell you whether or not there's a problem. Because if I tell someone, I'm really concerned about your knowledge base, and they say, I've heard that before, but I think I'm okay, there's a whole different level of problem here. If I hear that, that's something I'm telling the program director, and that's almost a behavioral problem, not a medical knowledge problem, because they're not accepting the feedback. If I say, I'm really worried about your medical knowledge, and they say, I am too, I've been reading, I'm not learning, I don't know what to do anymore. Now you're on a whole different pathway, and we'll talk about determining a remediation pathway in just a sec here. They are most likely going to tell you they have never heard this feedback before. And it's not that your feedback is different. It's that they just never really recognized it before. So if your feedback is different from something if it's truly different from something they've heard before, is that bad? No, not at all. It just means you're seeing something that other people haven't seen. Sometimes there's a reason, and it's a correct reason, and sometimes it's that you do things differently, or sometimes it's that for whatever reason they didn't react to you the same way others do. We all have people we react with better. That's okay. Give the feedback anyway. If it's wrong, no one will reinforce it, and it won't be a persistent problem. Now, if you're the first to give negative feedback, or you're the good guy or the bad guy, if it's done right, you're the good guy. Because if it's done right, you're the one who cared enough to help them. If it's done badly, if you say, listen, you need to read or I'm going to make sure you don't become a doctor, that's different. Now you're the bad guy because now you're threatening them. If you're the first one to give them feedback, it's important to put it in context of why it's important. What is so key about it? And how do you do that? You give it honestly and you make it a two-way discussion. Now, this is one of my favorite quotes. John Kenneth Galbraith was a Nobel Prize-winning economist. I use this quote a lot. Faced with a choice between changing one's mind and proving that there is no need to do so, almost everybody gets busy on the proof. I love this. Most of us say we want feedback. My personal theory is that 100% of people say they want feedback. 90% of them think they're really good at getting feedback. In reality, it's probably 10% who are. Now, as a recruiter, when I recruit med students or residents or faculty, this is what I'm looking at. Because everybody's going to make mistakes, and what I want to know is when they make a mistake, will I be able to help them fix that mistake? Will they see that there was a problem, and will they work on it? Because if they're not going to work on it, there's no point in my trying to teach them. I ought to just say, okay, this isn't compatible with our minimal standards. You need to go. So this is absolutely key. When you tell them there's a problem, how do they react? If they nod and smile and say, yes, sir, yes, ma'am, yes, ma'am, that's not a helpful response. If they apologize, that's a pretty good response. If they say, how do I fix this? Now you're into something. And now you can make suggestions, or you can say, you know what, I don't know, let me turn that over to the program director. Because the good news is that when it comes to the educator and the program director, or the educator and the clerkship director, or the educator and the dean, this is you. Might not be the nicest car in the shop, but you're not the program director. You're not the one who's got to deal with the calamity. That's the good news here. That's amazing news. Because you're going to dump this on their lap and say, hey, listen, I told them they needed to read more, and they said, I've been reading, I don't know how to fix it. It's your job. You get paid the big bucks to be the professional educator. Fix it. That's the really fun part. So everybody has something like concern status. At Maricopa, we use concern status to say it's the non-reportable remediation. This is where we say you're not performing up to minimum standards, but I don't want to label you forever. So let's change the case I've given you a little bit. PGY2, hardworking, professional, very well liked, follows direction wells, but now they're on concern status. We've identified, because we've gotten good feedback and a good interaction with the resident, we've identified that there's a problem and it's not making progress. We identified it in late PGY2. So now they're on concern status. It's internal. It's decided on by a committee. That's very important. You can never expect a program director or a dean of students or to do anything unilaterally about these for two reasons. One is it leaves them open to a charge of bias, and two is sometimes they really don't know if the problem has raised to that level, because the folks in those positions very often don't work one-on-one with them. If you think about an internal medicine residency that may have 60 residents, A residency director could theoretically get through the residency and almost never have staffed a case directly. So you can't expect them to unilaterally make decisions like this. It should be decided on by a group that examines all the evidence, pro and con, the complement as well as the concern. And concern status comes with defined goals and consequences for failure. It requires some mandatory touch bases at defined points. It'll have some objective criteria. So for this person, it might be you're going to take the departmental quizzes, and if you fail more than 2 in any 6-month period, that's grounds for advancing. But it will also come with helpful things like you will participate in active learning. So every month when you check in, I want to see your notes from reading. Every month when you check in, I want to see that you've done 400 questions out of this question data bank. So if you're the faculty member and you're seeing this person who's on concern status, what might you do differently? Well, there are a few questions to answer first. The first question is, if you're getting a resident on your service, do you want to know that they're in formal remediation? Sometimes it's really helpful to have a blank slate so that if you come up with an opinion that they're behind, at least you've given it to them fairly. You've avoided what's called a negative attribution bias. And a negative attribution bias, we all have these. If I tell you that a resident has weak medical knowledge, every time they miss a question, you're going to say, oh yeah, that's because they have a weak medical knowledge, and it's going to reaffirm your pre-established belief that they're weak. On the other hand, if you know nothing about them and you come to that conclusion, that's a fair shake. They've gotten a fair shake, and it hasn't worked. Now, on the other hand, sometimes in concern status, you need to know it. Because sometimes, for example, if I'm rounding on an internal medicine team, and I still do some internal medicine, so when I'm up there, I don't necessarily watch the residents interact with the nurse, but if I know that resident has had problems interacting with nurses, now I'm going to go ahead and ask the questions. So, why are they on concern status? What are their goals and objectives? I may or may not want to know that as the educator. During concern status, though, we're going to come back to this concept. Your job is to give the resident or the student the opportunity to succeed. If they choose not to take that pathway or they can't take that pathway, that is not the attending's issue. It is theirs to complete. So should your evaluation of them be tougher or easier? And the answer is neither. It should be fair. You're in the problem area, if you know what the problem area is. In the problem area, did they meet minimum standards? If they did not, they probably need remediation somewhere. That might be repeating the month. That might be a plan of learning. It might be neuropsychiatric testing to see whether they're an adult onset dyslexia. Very uncommon. We tend to use that excuse a lot. But let's face it, when someone says, I'm a bad test taker, chances are it's not that they're a bad test taker. The most common reason for being a bad test taker is not knowing the answers. So, did they meet minimum standards? Evaluate them fairly. Don't try and pre-label them. Don't try and make the evaluation friendly or mean. Be honest. Say what you think. So, which one are you? Judge, jury, executioner? Are you a advocate for one or both sides here? What's your role? Are you a witness? Well, it depends. If you're the faculty in remediation, I'd say you're definitely not the executioner. That's the program director and their clinical competency committee or the student progress committee with the dean. You're not the judge, although you have a judge-like role. In your evaluation, you have to recognize that your evaluation is going to have much more meaning because this person's under the microscope. It should specifically focus on the area of concern, and you have to talk to the resident because otherwise they're going to feel blindsided, and that evaluation will get used in ways that you don't want happening. If you evaluate them and don't talk to them, and they say, he never talked to me, he never said this, your evaluation becomes much less meaningful. And if you're not sure what to write, take the evaluation to the program director who will ask you the right questions to get you to articulate what it is you want to put down. So let's say that person on concern status or the equivalent of concern status doesn't take the opportunity. What next? This is our PGY2 who's now on probation. So what's the difference between probation and concern status? Probation is externally reportable. This has to be reported to the state for a resident. It has to be reported on the dean's letter for a student. It's reported to state boards. It's reported every time the person looks for credentialing or for a new state license. Probation must be decided on by a committee. The sole exception to this is where the faculty is the sole person in that training specialty. So an example of that might be a subspecialty fellowship where you have one person who does corneal work and he's the guy who runs the fellowship. That's about the only time you can do this without a committee. There are defined goals and consequences for failure. There are mandatory monthly meetings again, but what might you do differently here? The same questions apply. Do you want to know about the probation or not? Does the program director want you to know about it or not? Because we have the same risk of the negative attribution bias or the fresh view. So should your eval be tougher or easier? Well, it depends. If this person's really demonstrating that they are not capable of doing the job, your evaluation has to be pretty focused. It doesn't mean you should be targeting them or trying to get rid of them or anything like that. It just means it has to focus down. So, if your resident is on probation, what should you expect? Let's face it, if you've ever had your job threatened, chances are you got pretty scared. Chances are you got pretty desperate. Chances are little things got magnified. So if someone says I have a deficit in my medical knowledge, any PIMP question I don't know the answer to, I'm going to make an excuse for. Now, I don't like it when people get defensive, but it's normal. I have a teenage daughter. When I say, why didn't you clean your room? She's got an excuse. I understand why she has the excuse. It doesn't mean it excuses her not cleaning her room. And we work through these things to say, listen, I'm trying. So in the person on probation, when you have to give them feedback, you're giving them feedback, but it's important to couch it under, listen, I don't think this is a big deal. For tonight, I'd like you to read about the use of endoscopy in the workup with chest pain. And I focus that way. So what do you do differently? Are you allowed to pay closer attention? Absolutely. At this point, you better pay close attention, because your evaluation as the faculty member is really going to play a pivotal role in saying, is this person unfit to move on or unfit to stay in the program, or is this person making strides and getting better? So which one are you here? Definitely not the executioner, definitely not the judge, definitely not the jury. Now, if you serve on a clinical competency committee or you serve on student progress, you may be on the jury, but in your role as a faculty member who has this person on service, you are the witness, and then you can be an advocate for one or both sides. And that's a key. Those are key roles to take. So there's a tendency to feel like I am the law. I am the judge, the jury, the executioner. You absolutely should not, because remediation is not your responsibility, it's the resident's responsibility. Your job is to provide them the opportunity to succeed and to report on it fairly and accurately, and to stand by what you say to the resident and to put it on paper. They have to be the same thing. So you ready for the good news? Regardless, when that rotation is done, they are not your problem anymore. Give it back to the program director. Give it back to the dean and the progress committees. And at the end of the day, if you lead a horse to water and they don't drink, it is not your job to keep dragging them back to the water. At some point, the residents got to take this on. The failure is not yours and is not the program's. It's the residents. It's the students. So, termination, non-renewal. Because let's face it, this is where some of these things go. Not everybody is cut out to be a doctor. Every once in a while you meet someone, and I haven't had many in my career, but I've had them. There are times when you just have to say enough is enough. You're not going to make it in this pathway. So, things to remember. You will not be the deciding factor whether or not someone is terminated or not. That's a committee decision. No one person should be doing that, because let's face it, who wants to be sued over potential and be accused of bias? Let the committee do it. Your experience with the resident can be reviewed, but termination is always from a group. It's always done in consultation with GMEC, student progress, what have you. So let's talk about a case that's a little different. We're going to pretend that we've either fixed or terminated that last resident. I'll give you a different one. What about this guy? He's an above-average intern. You'll like him. He works hard. He's bright. He takes good care of patients, gets along with people. But now he's a PGY2. He's showing up in a more supervisory role. And for the last couple months, he's just not himself, to the point where he just looks bad. He's not on his game. What's happened so far? Well, 2 months ago, his evals became marginal. Last month, he was put on concern status because people said, you know what, all of a sudden, you're not showing up on time, you're not really doing the job. So they gave him the clinical competency committee gave him goals. They said, you will show up on time, you will pay attention to detail, you will provide proper supervision to your interns, and you'll be professionally attired and made up. So day one on your rotation, he shows up late, he's not focused, and the interns are running the show. So what do you do after rounds? Because let's face it, when this happens and you know the background to this, you're like, oh, I see the problem. I see what's going on. So what are you going to do? As faculty, we very often feel responsible for this. And this is one that maybe we can take some responsibility for. We can say, you know what? He's having a hard time. Let me talk to him. And there are a few ways you can talk to him. You can take him out to the woodshed, use the paddle. You can try and be the good guy and sit down and say, so how's it going? What's going on? You know, you seem different than last time I worked with you. Sometimes that discussion will happen in a more casual setting. So if you're going to meet someone at a bar to have this discussion, there are reasons why that's not a good idea, but there are also times when it's right. Maybe you know the guy socially a little bit. They're in your religious institution. You know their family, something like that. There are times when that can be appropriate. Now, regardless, you're going to need to find a private place to chat. And there are 5 main points here. The last one of these is going to be the one we're going to focus on, but you're going to review the goals of the rotation because you're going to have to point to something in those goals that's where the person's going to be failing. And so you can say, listen, I saw that you were late today, and that resulted in the interns making some mistakes. And if you'll see here on your PGY specific goals, on your rotation goals and objectives, you'll see here that you're supposed to provide direct oversight to the interns. You can review the goals of their concern status if you know what they are. You can make sure he understands them, because sometimes he's like, oh, I thought that meant I had to be at lecture on time. I didn't realize it applied to the wards too. Okay, that's a bad example, but you get the idea. It's going to be important to ask him what's going on. Now, I would not ask, hey, are you depressed? Because there's some HR rules about that. What I would say is, how do you think things are going? What's going on? You seem different than the last time I worked with you. You all right? Now, she may say, I'm fine. They may say it's none of your business. They may also say, you know what, my wife left, I'm getting a divorce. And that time, people decompensate. And they may not have had that opportunity to say that before. It is absolutely crucial because let's face it, when doctors are under stress, they protect their work above all else. So by the time this person is showing up late and unkempt and isn't doing their job, chances are the rest of their life has fallen to pieces so amazingly badly that they just can't protect anything anymore. Because given the choice of family life, personal life, and medical practice, doctors protect medical practice. So by the time the medical practice is getting bad, everything else has fallen apart. So ask what's going on. They don't have to tell you. You're their boss. Think about what you'd like your boss to know about your personal life. They don't have to tell you, but I think it's crucial that they have the opportunity to. Not so that you can fix their problem. You're not a marriage counselor. You're not a psychiatrist. You're not their doctor. You're not their priest. But ask them what's going on. If they say nothing, okay, you've asked. You've tried to do the right thing. The big thing here is, you're assessing if they're fit for duty. Because let's face it, sometimes they come in and they're like, oh, I didn't know that guy got a central line. Yeah, the intern did it. Well, maybe the intern isn't allowed to do central lines on their own. Maybe that's going to cause some patient care problems. So the ACGME definition of fit for duty is mentally and physically able to effectively perform the essential functions of the position. So, in the ACGME definition, down at the end it says it's to promote patient safety. Are they able to take care of patients? And at the end of the day, this is all we are measuring. We are not measuring if they're a good human being. We are measuring whether or not they are able to take care of patients safely. Being nice to nurses has an effect on patient safety, and we have to recognize that here. So we're going to assess, is this person fit for duty? Now, we are not their treating physician. We are not a psychologist. We are not a bartender. We are not the ones who are going to be creating our differential diagnosis and our treatment. However, when we ask, is everything okay, we may learn about substance abuse. We may learn about depression. We may learn about stress or fatigue, or we may learn that this person is psychologically checked out and they just don't care about the patients. We may also learn that the guy says, yeah, I was just diagnosed with diabetes. They haven't gotten my medications right and I'm peeing all night so I can't sleep. There's lots you can learn there. So there is a treatment to all of them, but all of them, with you as the faculty member, are not your responsibility. It is a crucial responsibility that you get this person to the program director who has all of those resources at their disposal. They can send them for drug and alcohol testing. They may have learning counseling. They may have learning specialists. They may have a list of counselors and how they can pay for them. They have all these tools at their disposal. And the good news is that this is not your problem. Your problem is to report it and make sure the PD understands and reacts appropriately. But it's not your problem to treat them. And I stress that because you don't want to be both their mentor or their advisor or their supervising attending as well as their doctor. That's not fair to you. It's not fair to them. You've got to separate the roles and pretend you're a boss. So be a boss. Send them to the person whose job it is to make sure. So when I think about remediation, I think about it like a patient of mine. Good doctors treat a disease. Great doctors treat the patient because the disease will have implications within the patient and that will change your management. So when I'm doing a remediation, I treat the cause. In some cases, remediation can make things worse. So if I say, you really need to read, I'm really concerned about your reading, and the problem is that they can't read because they're so depressed, they can't stay awake, they've got an atypical depression, they can't stay awake at night to read. If I put stress on them by saying, God, you really stink as a physician, your medical knowledge is killing people, that's going to make their stress worse, that's going to make their fatigue worse, they are not going to get better. So we think we're helping when we say your knowledge base stinks. Sometimes that makes it worse. So if the resident isn't fit for duty, they can't work. When the resident isn't fit for duty, the first thing you're doing is you're calling the program director. If they're not around, you're calling the APD or the chairman or the DIO, who may be the vice chair of academic affairs. Within the medical school, you may be calling the dean of students. You may be calling the rotation director, but you're getting help and saying, this person should not be taking care of patients. There's a problem. Remember, depression can be the same as a tremor. If you saw a surgeon with a tremor, you'd immediately tell someone. If you see someone whose medical knowledge is so bad that they're going to hurt someone, pretend it's a tremor and tell someone. Ensure the patients are covered. That's the key part, because that's what fit for duty is. Can they take care of the patient safely? And let's face it, you're the attending who's getting sued if something goes wrong, so you might as well make sure they're taking care of the patient well. So let's wrap up here, because if you've been listening to this with just my voice droning on against these slides, I compliment you. I'm glad you're still with me. Remediation is the resident's chance to correct areas where performance is beneath minimum standards. The two things there are resident's chance and minimum standards. It's competency-based, it's based on a specific objective, and it requires feedback. The steps of remediation involve something like concern status, whether they're a med student or resident, some unofficial remediation, then there's probation, which is reportable, and then there's termination, non-renewal, you may say non-promotion in there. The assignment to one of those pathways should be done by a committee, not an individual. And that means that whether you like it or not, and chances are you like it, you're not going to be the one person who's on your own defending this if something goes wrong. When you're working with a remediating resident, your job is to provide the chance for success. You should review the area of focus, you should give feedback, you should evaluate them fairly and accurately, but you should really avoid seeing yourself as jury and executioner. See yourself as a patient care advocate and someone who cares about the resident's development. When a resident isn't fit for duty, though, you are absolutely a patient care advocate, you are a resident advocate, you are a medical student advocate. Get them to the right treatment. And the best way to get them to treatment is by sending them to the person whose job is to manage them from an HR standpoint. Don't let the surgeon with the tremor operate. Don't let the resident who's too depressed to focus take care of your patient. When in doubt, make it somebody else's problem. Call the dean, call the residency director. That's going to wrap it up for me. Thank you for staying with me this long. If you have any questions, please email me. Happy to answer them. Thank you very much.